Good afternoon. Topic is clinical profile of patients with ethambutol optic neuropathy. No financial interest. Ethambutol is used in treatment of infections.
Excuse me, doctor, you can remove your mask and speak probably.
Ethambutol is used in treatment of infections caused by mycobacterium species including tuberculosis. An important and well-reported side effect of the drug is toxic optic neuropathy, which if not picked up early can result in variable and often significant visual function loss. Significance. Why this study? RNDCP initially adopted twice-weekly regimen for treatment of drug-sensitive TB. The revised RNDCP guidelines 2016 has extended the use of ethambutol from initial 2-month intensive phase to remaining 4 months of continuation phase, as well as shifted from alternative regimen to daily regimen. The continuation phase in both new and previously treated cases may be extended by 12 to 24 weeks in certain forms of TB like CNS, skeletal, and disseminated TB. Aim to describe the clinical profile of patients with ethambutol optic neuropathy from a tertiary eye hospital. The materials and method. This is a retrospective observational study conducted from October 2020 to June 2022. 32 eyes of 16 patients with ethambutol optic neuropathy were studied. The parameters used are best corrected visual acuity, color vision, contrast sensitivity, HFA, pattern VEP, flash VEP, and OCT RNFL. The symptoms. Majority of patients presented with the complaints of defective vision within 2 to 3 weeks of onset of symptom. Mostly in the last 2 months of ATT treatment. 5 patients presented just after the completion of treatment. A patient who received prolonged ATT for bone TB presented with defective vision after 14 months of treatment. Coming to the results. Most of the patients included an age group of more than 60 years. No sex predisposition noted. Most of the patients included an extrapulmonary group. Coming to vision comparison in initial and final visit, the BCV in dogma during follow-up showed a marginal improvement from 0.8 to 0.65. The observed difference was not statistically significant. The p-value was noted to be 0.141. HFA or octopus field analysis done in all patients except 3 due to poor vision. Most of the patients presented with the centrocecal scotoma, 20% presented with the bitemporal field defect. We also done MRI to rule out neurological causes such as compressive lesion. In 2 patients, thinning of optic nerve and chiasma seen. In 1 patient, mild to moderate cerebral atrophy with thinning of optic nerve noted. Improvement field only in 2 patients after stopping the offending drug. The color vision was abnormal in majority of the patients, normal in patients with the vision 6/9 or better. OCT RNFL was normal in 82%. 2 patients showed thickening of RNFL in superior and inferior quadrant. 1 patient showed temporal thinning. Coming to disc evaluation, it was normal in 69%, disc pallor in 18%, hyperemic disc in 11%, disc hemorrhages in 2%. 36% of normal discs presented as temporal pallor on follow-up visit. VEP done in all patients, flash VEP done in patient with vision less than or equal to 636. Pattern VEP done in 5 patients. 3 patients had normal latency with reduced amplitude. 2 patients showed additional prolongation of P100 with a decreased amplitude. Flash VEP done in 11 patients. 7 patients showed prolongation of P2 with reduced N2 P2 amplitude. 4 patients shows abnormal indistinguishable waveforms. This is the right and left field analysis. Same patients flash VEP showing prolonged P2 and relatively normal amplitude. The treatment advised was ethambutol was stopped in almost all patients and continues on rifampicin and isoniazid. Neurovitamins were also supplemented. Coming to the discussion part. Most of the patients who manifested ethambutol toxicity was elderly patients over 60 years. Extrapulmonary TB was prominent, which would have necessitated prolonged or extended therapy, adding to the risk. The study conducted by Pragati Garg et al. Is a prospective study of ocular toxicity in patients receiving ethambutol as a part of previous guidelines noted that change in visual acuity from 0.26 to 0.04, the p-value was less than 0.001, which was statistically significant. The similar study conducted by Menon et al., a prospective evaluation of visual function for early detection of ethambutol toxicity based on previous guidelines noted that vision improved in almost all patients after stoppage of the drug. But in our study, based on revised RNDCP guidelines, change in visual acuity from 0.8 to 0.65, the p-value was 0.141, which was not statistically significant. HFA field analysis showed centrocecal scotoma in most of the patients. VEP, pattern or flash, was found to be affected in most patients, similar to a visual field, thus making this investigation most useful in picking up early toxicity. The OCT RNF was normal in majority of the patient initial visit and therefore not useful in detecting toxicity. Disc appearance can be normal, hyperemic, or sometimes with peripapular hemorrhages or mild temporal pallor. In our series, 36% of those with normal disc at presentation subsequently developed temporal pallor on follow-up, indicating ongoing optic atrophy. So the point is, ethambutol toxicity is a cause of potentially permanent vision loss and need to be addressed in current scenario of longer duration of its use under new treatment guidelines of India. Even after stopping drug, vision acuity did not improve significantly in our case series. Disc appearance, which was normal initially, on follow-up showed temporal pallor, which showed ongoing optic atrophy. PEP, pattern or flash, was found to be affected in most patients, thus making it most practical in picking up early toxicity. The limitation of the study, this is a retrospective study, small sample size, simultaneous intake of isoniazid and linezolid not taken into consideration. These are my references. Thank you.
Thank you, ARCHA. Nice study. I have just two questions for you. One is that did you look at the weight of the patient and take that into consideration as to the reason being, you know what I'm talking about? Even though ethambutol has been increased, the RNTPC guidelines are all weight segments. So someone at the lower end of the segment and higher end of the segment, there's totally different dosage going in. So did you find any difference like that in your study based on the weight?
No, sir, we gave 20 milligram per kilogram body weight for all patients.
But that's not what RNTPC does. They don't follow 20 milligram per body weight. They give according to weight groups. So people in one weight group will get the same dose, irrespective if where they fall in that weight group. So that could have been looked at. And one last question. You never mentioned anything about how long it took? Was there a dose dependent thing as how much of dosage of drug led to it? Did you look at any of those parameters in your study? As in how long after ethambutol was started did they develop?
We followed up the patients for 6 months.
Yeah, no, based on how long of taking ethambutol they presented with ethambutol toxicity. You did not look at that in your study?
After 2 months. Most of the patients presented with after 2 months of the treatment.
Okay.
So you started your study when the patient approached you with some problem.
It's not.
So then, again, we cannot say that after how many months this toxicity has started, because they have approached you. Some people might approach you earlier, some people might approach you later. So probably I think you could connect with the, general pulmonologist or something to take it up before, so that you understand how frequent you should do the follow-up, so that you pick up the ethambutol toxicity even earlier, because your study shows that there is an ongoing process in spite of stopping the drug. That's scary. So, patient is losing out.
Thank you.